Hello everyone, welcome to the module on neurogenic bladder. Today we're going to talk about concepts of bladder storage and emptying. We're going to talk a little bit more in detail about peripheral neuroanatomy of bladder storage and emptying. And finally we're going to end up by talking about different neurological defects and diseases that affect lower urinary tract function. And we're going to go through all of these separately at the end of the lecture. So starting with the bigger level concepts, neurogenic bladder is a term that's used to describe lower urinary tract dysfunction resulting from a neurologic disease or process. And I just want to take a moment to talk a little bit about this term. It's often thrown around a lot in patient notes, but it really should only be used in a pure sense when there is a specific neurologic condition or lesion that is being referenced. It's not a homogeneous term. There are several different manifestations of neurogenic bladder, and the level and severity of the neurologic lesion can manifest as varying but often predictable symptoms ranging from disorders of storage to those avoiding dysfunction. So I'm going to break up bladder pathophysiology or physiology to start with in terms of filling in storage phases, and then in terms of the voiding or emptying phase. So starting with the filling and storage phase, we're going to further break that down into the reservoir, which is the bladder, and the outlet, which is the urethra and prosthetic urethra in males. So the reservoir during filling should allow for accommodation of increasing volumes of urine at low intravesical pressure, and we often refer to this term as compliance. You also should have appropriate sensation as the bladder fills. So if the sensation is too heightened, you're going to be running to the bathroom, and if it's too decreased, you may not have any indication that it's time to urinate. So appropriate sensation is important. It's also important to have the absence of any involuntary detrusor contractions, because those are going to result in a sense of urgency or sometimes even with leakage. Now, during filling and storage, the outlet is also important and has to be closed at rest and remains so during increases in intra-abdominal pressure. And if this isn't the case, then you result in leakage. All right, so moving on to emptying and voiding. The reservoir during emptying needs to have a coordinated bladder contraction of adequate magnitude and duration so that the bladder can empty completely every time. And the outlet needs to have an absence of anatomic obstruction and concomitant lowering of resistance at the level of both the smooth muscle of the bladder neck and proximal urethra and at the level of the striated muscle that surrounds the urethra. So those are sort of the broad concepts of what you want to have during normal voiding. Now we're going to get a little bit into peripheral neuroanatomy and talk about the hypogastric, pelvic, and pudendal nerves. So these are all peripheral nerves, starting with, and I put together this table, which I hope that you find helpful, starting with the hypogastric nerve. This is part of the sympathetic nervous system that's located in the thoracic spine, levels T10 to L1, and the ganglia, I put this column in here because sometimes there are questions on this on the in-service exam. The ganglia are located anywhere from the central nervous system to the end organ, okay? And the neurotransmitters for the sympathetic nervous system are mainly adrenergic, but can also be cholinergic. And the function of the hypogastric nerve in the sympathetic nervous system is to inhibit the bladder from contracting and to excite the bladder base and urethra. So this is what happens during the storage phase. All right, moving on to the pelvic nerve. This is part of the parasympathetic nervous system, and it's located in the sacral spinal cord from S2 to S4. The ganglia, importantly, are located on the end organ, or close to the end organ, which is the bladder in this case. And they're mainly cholinergic, but can also be noradrenergic as well. And the purpose of the parasympathetic nervous system is to excite the bladder and relax the urethra, and this is what you want during normal voiding. And finally, we have the pudendal nerve, which is part of the autonomic nervous system, also located in the sacral spinal cord, S2 to S4. And I've seen a lot of questions about this. They often like to ask you about this. It's Onuf's nucleus. There are no ganglia because it's autonomic, and the purpose is to excite the external urethral sphincter, and this is activated during the storage phase. And this is just a visual to go along with the different parts of the nervous system. I find this helpful. You have the hypogastric nerve, again, correlates with the sympathetic nervous system, it's shown to the left. The pelvic nerve, which correlates with the parasympathetic nervous system and the sacral spinal cord. And the pudendal nerve, again, this correlates with the somatic or autonomic nervous system and also the sacral cord. And I just want to point out one thing that helps me remember the order of these nerves is that they go in alphabetical order, so hypogastric, pelvic, and pudendal nerve, and that's in order of the location on the spinal cord. So this is one image that I find really helpful to sort of burn into my brain as a reference point. And this slide is just to show you sort of the switch between storage and emptying. It really is a sort of switch between the sympathetic and parasympathetic nervous systems. So the sympathetic nervous system we think of as fight or flight, right? And this is when we're running from a snake, as shown in this picture here. You don't want to urinate during that time, and that would definitely slow you down. And so this is the storage phase of voiding. The parasympathetic nervous system, on the other hand, you see this man relaxing. It's the rest and digest phase, and that's when it's appropriate for us to empty our bladders, and so it correlates with the emptying phase. So now we're going to go into a little bit more detail about the storage and voiding reflexes, and I'm going to take you through each of these figures. We'll come back to them in just a minute. This is just a map of where we're going. So starting with bladder storage, the bladder functions as a low pressure reservoir. And bladder pressures remain low and relatively constant during filling, and these are the viscoelastic properties of the bladder, and that's an important concept to understand. And if you see here in this cystometrogram, you see that the bladder, as the bladder fills or increases in volume as you move from left to right, the pressure only increases very, very slightly. And then until you have a voluntary bladder contraction that would result in voiding. So I kind of think about the bladder as a balloon. So a balloon is stretchy, and when you blow up a balloon, you blow air into a balloon, and the more air you blow in, it doesn't really matter. The balloon will sort of stretch to accommodate that air, and the pressure remains constant. Okay? That's how a healthy bladder should be. If the balloon is really thickened, and it's like a thick rubber balloon, like a hot water bottle, you can blow air in, and it gets to a certain point, there's no more room or space for the increased pressure or air to go, and so it'll just come right back out at you. So this is analogous to a neurogenic bladder in some cases, where the bladder wall is really thickened, the compliance is poor, and there's no way that that bladder can accommodate the increases in pressure. So the increased pressure either comes out, and it would be like urethral leakage, or it can go up the ureters to the upper tract and potentially cause renal problems or sequelae. So in the storage phase, it's also important to think about the afferent pathways, which carry sensory input. And there are two different types of fibers, and these are sometimes tested on, so I want to mention here. The A delta, which are myelinated fibers, these are the ones that sense bladder fullness and tell us when it's time for us to go to the bathroom. And the other type of fibers are C fibers, which are unmyelinated, and they sense stretch and nauseous impulses, so bladder pain. So one thought is that these are overrepresented in people with interstitial cystitis / bladder pain syndrome. So here's the storage reflex diagram, and I'm going to go over this in a little bit of detail. And again, I want you to think, every time you think of storage, think of sympathetic nervous system, right? So sympathetic, hypogastric nerve, storage, those all go together. So basically what's happening here is as the bladder stores urine, it's slowly getting distended and producing low-level firing of afferent pathways. So those afferent pathways that we talked about on the last slide, sending information to the central nervous system that you might want to think about it being an appropriate and socially acceptable time to urinate. Okay? So as you're storing, however, you want to be able to hold your urine without any leakage or any problems, and your sympathetic outflow is being fired, okay, through the pudendal nerve like we talked about in the last slide. So in a little bit more detail, you have the hypogastric nerve, and this activates beta adrenergic receptors that inhibit the detrusor muscle. Okay, so the muscle is nice and relaxed during bladder filling, which is what you want. And at the same time, you have alpha adrenergic receptors that are contracting the bladder outlet so that you don't have any leakage of urine. Okay, and just as an aside here, think about the medication mirabegron. So that is a beta-3 agonist. So you're promoting the relaxation of the bladder. Okay. And the other thing that I want to mention during bladder storage is via the pudendal nerve, which is our somatic nerve here. You are contracting or activating the external urethral sphincter. So that is another mechanism by which you're able to store urine. Okay? So moving on to bladder emptying. This can occur either voluntarily or involuntarily, and that would be the case in an infant or in an individual potentially with neurogenic bladder. So on the right, there are two cystometrograms with EMG tracings. The top one is a normal adult during filling and emptying, and you can see this is the same cystometrogram that I showed you before. The bladder fills under low pressure, and then you have a voluntary contraction. Before you have that voluntary contraction, however, you first have relaxation of the pelvic floor and external urethral sphincter, which is shown in the upper EMG tracing. So that allows for the bladder contract. That happens right before, the bladder contraction. Now in the panel below, this shows an abnormal finding that can happen with neurogenic bladder, where you have an uninhibited bladder contraction or a detrusor contraction. So this is not a voluntary contraction. And at the same time, you have a contraction of the pelvic floor. So this is dysynergic sphincter, okay? So the bladder and the sphincter are contracting at the same time. So that's not what you want to have happen. Now in an infant, it's a little bit different. You have basically a similar curve to the one on the top. The bladder fills, and then once the bladder reaches a specific volume, you have a reflexic contraction. So it's not voluntary, but it looks similar to that. All right, now moving on to the voiding reflexes. So here, once your afferents from your bladder have signaled and your bladder is very stretched and you feel like you have to go to the bathroom, you might be getting that sense of urgency. All this information is getting sent through these afferent pathways to the brain, and once your brain synthesizes that information and determines that it is a socially acceptable time for you to go to the bathroom, then the switch goes off and you change from a bladder storage phase in the sympathetic nerve and the sympathetic activation to just the opposite, bladder emptying phase via the parasympathetic activation. Okay? So what's happening here is you're actually activating something called the spinobulbospinal reflex pathways through the pontine micturition center, which is indicated at the top of the slide here. That again is stimulating the parasympathetic outflow to the bladder and sphincter muscles and inhibiting the sympathetic and pudendal outflow to the bladder outlet. Okay? So in a little bit more detail, we're focusing on the pelvic nerve here, and there's what is happening is the release of acetylcholine, which is binding to M2 and M3 receptors, and these are muscarinic receptors, and that's causing a bladder contraction. You can also have non-cholinergic transmission of ATP, which binds to P2X, which is a purinergic receptor in the bladder muscle, and both of those cause bladder contraction. And as a side note here, we're all familiar with anticholinergic medications. These are aimed to block the binding of acetylcholine to the muscarinic receptors and hence inhibit bladder contraction. Okay, So now that we've gone over some of the bigger concepts and gone into the storage and voiding neuroanatomy, it's now time to put it all together and try to make some sense of this. So we're going to talk about what happens when you have nervous system damage and resultant lower urinary tract dysfunction. So the level of the damage to the nervous system often correlates with patterns of lower urinary tract dysfunction. And this, I think, is a really helpful image, and this is taken out of a review article written by Paniker, and it's visually showing you the different levels of the central nervous system and the corresponding bladder and outlet lower urinary tract dysfunction. So let's walk through this together. Let's start at the top, so with suprapontine lesions highlighted in blue there. And these are any lesions obviously above the pons, so including the brain. And these are patients who have things like stroke or traumatic brain injuries that are fairly significant. Urodynamics would show something like detrusor overactivity, so they have overactive bladder symptoms. And the outlet, is indicated on the right there, is normoactive, so nothing is happening to the outlet with this level of lesion. Okay? Now moving down to the thoracic spinal cord, so this is anything below the pons but above the sacrum, you can have both storage and voiding symptoms. And these are usually the ones that were the level where we're most concerned about resultant damage to the upper urinary tract. So you can have what's called an overactive bladder from detrusor overactivity. You can also have what's called DSD, detrusor sphincter dysynergia, where the outlet is overactive. So there's a dyssynergy between the bladder and the outlet, so they're both firing at once. The bladder's trying to evacuate urine, and the outlet is trying to restrict that. They're competing against each other, and the reason that's so dangerous is that can cause big increases in intravesical pressure and resultant damage to the upper urinary tract. Okay? And finally, we'll go to the sacral lesions. These are, this predominantly affects voiding symptoms. Usually what happens is you have an areflexic or acontractile or hypercontractile bladder, all the same sort of thing, and the bladder is basically underactive, and typically, depending on the lesion, the outlet can either be just normal active or underactive. And these are, for example, the underactive outlet, it would be a wide open bladder neck. Sometimes you see that in individuals who have a sacral lesion with spina bifida, and that would obviously result in leakage with stress maneuvers. Okay? So now we're going to go through different neurologic conditions and talk briefly about each of them and their resultant lower urinary tract dysfunction. So starting with stroke or CVA, over 50% of individuals with stroke have lower urinary tract dysfunction, so a high percentage. There's an acute phase which results in urinary retention from detrusor areflexia. And after the resolution of the acute phase, you can have detrusor overactivity with intact sensation. So oftentimes these patients are really bothered by sense of urgency, frequency, and urgency urinary incontinence. Next is dementia. The most common type of dementia is Alzheimer's disease, and urinary incontinence is the most common form of lower urinary tract dysfunction in these patients, but it can sometimes be difficult to determine the source. So it can either be underlying detrusor overactivity or loss of awareness or desire to urinate due to the dementia. And it can also be a combination of the two. So these can be very, very challenging patients to treat. Parkinson's disease. So this is a neurodegenerative disorder that affects the dopaminergic neurons, primarily in the substantia nigra. Overactive bladder is the most common form of lower urinary tract dysfunction in this group, but you can also have increased bladder sensation, such as urgency, frequency problems, detrusor underactivity, DSD, or bladder outlet obstruction. So there is a whole variety. Again, overactive bladder is the most common one and the one that's usually tested on. Multiple system atrophy, MSA. This is one that you don't necessarily see as often, but they like it for test questions, so it's certainly worth paying attention. It's otherwise known as Scheid-Drager syndrome. It's a progressive neurodegenerative disease of unknown origin. And these patients exhibit signs of Parkinsonisms in addition to cerebellar autonomic, including erectile dysfunction, that's a big one, and parietal cortical dysfunction. It's oftentimes more severe than Parkinson's disease, with earlier manifestation of more bothersome urinary symptoms. Oftentimes we see these patients before they're diagnosed, as urinary symptoms such as urgency, frequency, and urgency incontinence typically present 4 years before the neurologic diagnosis, and oftentimes urologists are critical in making that diagnosis. Detrusor overactivity is the most common, but you can also have decreased compliance, difficulty initiating and maintaining urination, and an open bladder neck, so it can be more complicated. Again, usually more severe than in patients with more straightforward Parkinson's disease. Multiple sclerosis, this is a demyelinating disease of the central nervous system. Symptoms include optic nerve dysfunction, I'm having trouble saying this, parietal tract abnormalities, ataxia, bowel dysfunction, lower urinary tract dysfunction, and sexual dysfunction. Lesions can present anywhere in the central nervous system, and presentation is varied. 10% of patients with MS present with lower urinary tract symptoms, and 80% develop, or more than 80% develop lower urinary tract symptoms. Overactive bladder is the most common manifestation, but you can also have stress incontinence, mixed incontinence, and voiding phase dysfunction. So it can be quite varied, and this is because the lesions are quite varied and change over time. Spinal cord injury. So injuries can be either complete or incomplete. They're potentially dangerous to the urinary tract, so we need to monitor these patients very closely. There's oftentimes a period of spinal shock, and this time period is variable, anywhere from 6 weeks to 1 to 2 years. During this time of shock, the bladder is acontractile, so this is the patient that we often get called or consulted on in the hospital. They just had, were in a motor vehicle accident, had an injury, and they're in urinary retention. So after the retention resolves with the period of spinal shock, you have characteristics based on the level of the injury that we talked about before. For example, if you have a thoracic injury, you would most likely have detrusor overactivity and symptoms related to that. It's important to look out for autonomic dysreflexia for anyone with lesions at or above T6, because this is potentially life-threatening. And this is also something that they like to test you on. Symptoms include an increase in systolic blood pressure. Oftentimes it goes well above 200. Headaches, flushing, piloerection, stuffy nose, sweating above the level of the lesion, and vasoconstriction below the level of the lesion, and dysrhythmias. So very important to be aware of this. Neurospinal dysraphism. This is malformation of the neural tube, including spina bifida cystica, which we call myelomeningocele, and spina bifida occulta. Myelomeningocele occurs in 1 in 1,000 live births, and this is a distribution of where the lesions are. Most of them, as you can see, are lumbar, lumbosacral, or sacral. And over 90% of individuals with myelomeningocele have lower urinary tract dysfunction, so it's almost ubiquitous. And this dysfunction can change over time, particularly due to spinal cord tethering. So again, very important to monitor. And depending on the level of the lesion, you can have detrusor overactivity, detrusor underactivity, and poor bladder compliance, which is one of the more concerning findings. Detrusor leak point pressure, which is the pressure at which a patient with a neurologic problem spontaneously leaks in the absence of a detrusor contraction, and that's an indication, if it's greater than 40 centimeters of water, it's an indication of risk for upper tract deterioration, and that was established by Ed McGuire. So cauda equina syndrome, this basically the dura opens at L1 into multiple tightly packed thin nerve roots that look like a horse's tail, that's why it's called cauda equina. And the main destination of these nerve roots are the lumbar and sacral plexuses, and these carry motor and sensory innervation to the lower limbs and pelvic organs. And motor and sensory symptoms of the lower limbs, buttocks, perineum, and abnormality of sexual, bowel, and bladder function often result. And this can be caused by spinal fractures, disc protrusions, and iatrogenic lesions, sometimes caused by spinal surgery. And also, The lower urinary tract symptoms that are common are underactive detrusor and loss of bladder sensation, and this occurs immediately following the neurologic insult. So that's everything that I'm going to cover today. In review, we started with concepts of bladder storage and emptying, and then we went on to talk about the specifics of the different, or the neuroanatomy, and then we talked about several of the different neurologic diseases and their corresponding lower urinary tract dysfunction. So I look forward to seeing you in class soon, where we can go into some of these concepts in more detail. Thank you.